question. How many half-used beauty products are currently living in your bathroom drawer? Too many, right? That's where U Beauty comes in. We test everything from supermarket finds to luxury splurges and tell you what's worth it. U Beauty, saving your skin and your wallet. Listen now wherever you get your podcasts.
You're listening to a Mamma Mia podcast.
Hello, well, friends. Welcome to your full body health check. I'm Claire Murphy, just getting through perimenopause one day at a time.
And I'm Dr. Mariam, and I'm here to help women get through this transition period without being labelled as crazy. You're not. What you're going through is real, and you sure as hell don't have to go through it alone. That's why we're here.
Thank God you are here. Today, we are talking HRT. Now, look, if there is a discussion that will divide a room of women faster than, debating whether having it all is a myth or marketing, is to HRT or not HRT. And, of course, HRT is hormone replacement therapy, which is what we probably most know it as. It's a question that's been caught up in a 2002 study, which we're going to discuss in a bit more detail with the expert that we have on today. It claimed that taking the combined estrogen and progesterone HRT medication increased your chance of a whole bunch of things, including breast cancer, which was really, really scary to hear. It kicked off a whole discussion about how safe HRT is, and that included other hormonal treatments like taking the pill, for example. That's all part of this discussion too. Is it okay for your long-term health? There were lots of things brought up in the wake of that, and it changed how doctors prescribed it to women. And so it really shifted the entire menopause space. So today we're going to try and break down all of your questions about HRT, from patches versus gel to whether there are non-hormonal treatments if you don't want to go down the HRT route. We'll also check into our quick consult room today to answer a question from Meg. And Meg's not feeling great about this.
Oh, no.
She's got a bleedy bottom problem.
Bless.
So we're going to try and sort that out for her.
Next, though, we look at whether there's any connection between a certain type of ear piercing and migraines and headaches.
Ooh, tell me more.
Well, we will, because we're going to med school next.
Welcome to med school.
Can getting your ear pierced stop migraines? Daith piercings are believed by some to mimic acupressure, specifically impacting your vagus nerve. Your vagus nerve is a big deal, but there is this idea that if you get that pierced, it impacts that vagus nerve and can interrupt the pathway that causes migraines or chronic headaches. Lots of anecdotal evidence about this, but here's the thing, Mariam, there is no scientific evidence to back this up, is there?
So, there's no actual scientific evidence to support that. It's like what you said, it's a bit of acupuncture, a bit of pressure on the vagus nerve that stimulates that pressure point. But at this stage, as you mentioned, anecdotal, not evidence-based. But there are lots of treatments for migraines. So I don't know.
Maybe try some of those first.
It's time for the checkup.
In case you're wondering who in your life might be perimenopausal or menopausal right now, we're talking about women who are sort of early 40s, so the eldest of the millennials. They are right at the start of their perimenopause journeys, and that goes all the way through until women who are in their mid-50s, which is like kind of the general window of perimenopause and menopause. So we're talking Gen X are like knee-deep in that right now. And I was reading the other day that Gen X and Millennial women are not going to do menopause the way that their boomer previous generations
Thank
did.
God.
Yeah, because we know that they were quite silent about it. They suffered in silence. They've been going through it without some of the medical help that we know that we can access. They were told that it was a women's issue that is dealt with behind closed doors. And we've talked about this before, but when we've talked to our mums about it, they were very much like, oh no, I had no symptoms of menopause.
Yeah, you did, Mum. You did.
Because we could see the rage and the brain fog, and you probably were experiencing a whole bunch of other stuff that you just didn't know at the time, and Google wasn't really hugely a part of their lives, so they haven't been able to really access all of the information that we do. But the conversation, of course, when we're talking about menopause, eventually does come back to how to treat the symptoms. Mariam, though, I noticed that when I've been talking about HRT, which is short for hormone replacement therapy, you reference it as MHT.
Yeah.
Why is that?
HRT stands for Hormone Replacement Therapy. It's been the go-to term for years, but it suggests we're replacing something that's broken.
Yeah.
And we know menopause isn't a disease. It's a natural transition like puberty, and we're not fixing it, we're managing it. So that's why we now use MHT, which stands for Menopause Hormonal Therapy, and it better reflects what we're actually doing, helping manage symptoms like hot flushes, night sweats. So MHT is the term now used in the Australian and international guidelines, like from the Australasian Menopausal Society and the Endocrine Society, and it just makes more sense.
If someone is listening to this right now and says, look, I'm keen to explore HRT or MHT for myself, how do you take that request to your GP? I personally was not successful with my own GP. I had to go through a menopause hub in order to be prescribed it.
Yeah.
But what do you suggest? Because I've been talking to other doctors about this. It wasn't just women who missed out on 2 decades worth of MHT prescription, but healthcare professionals were taught in a way that they believed the study results too. So they've missed out on an education and prescribing it for their patients. So how do I take this to you?
Yeah, great question. And I'm really sorry with your experience and that your GP didn't take your concern seriously. Unfortunately, it's still pretty common, and it's frustrating when you're really trying to get the support that you need during that transition period. So if you're looking to explore MHT or HRT and you want to be prepared, here's how to get the most out of your consult. Start by writing down all the symptoms you're experiencing, things like hot flushes, sleep issues, mood changes, brain fog, the vaginal urinary complaints like vaginal dryness, pain with sex, recurrent UTIs, all those sorts of
Needing
things.
to wee
all the time. Yeah. And track what your cycles have been doing as well over the last few months. This gives your doctor something clear and structured to work with. And even better, if you could head to the Australasian Menopause Society and download that symptom score sheet. It's a really useful tool to take to your appointment and help guide that conversation.
It might also remind you that you're having symptoms that you weren't aware are actually part of that.
Exactly. And if your GP isn't confident in managing menopause or perimenopause, which honestly, there are lots of doctors out there that aren't really confident in this space. Go there. They've got all these doctors with expertise in menopause listed. You just put in your suburb and it will list those doctors.
Oh, great. Yeah. So you can find it by location.
Yeah. And when you're in the consult, let your GP know, I'm here to talk about perimenopause, menopause, and whether hormonal therapy or non-hormonal therapy is right for you. So bottom line, go in prepared, take your notes, and don't be afraid to advocate for yourself or seek a second or third opinion. You do deserve proper evidence-based care. But in saying that, I do hope that these podcasts really empower females with the signs of perimenopause. But I guess all we can do now is really kind of educate females to advocate for themselves and give them this knowledge.
Okay, look, we have a lot more questions about MHT/HRT. So Professor Rodney Baber is going to help us out with that. He's going to get to the bottom of them, including patch v gel debate, which I know a lot of people are having right now, the risks and benefits of using MHT, and who is not a candidate to use it.
Hello, friends. It's Holly Wainwright jumping into your ears, not literally, that would be weird, to tell you about the next season of Mid and how it's all about you. You see, over the last 5 seasons, we've talked about everything on Mid, from marriage and divorce to hormones and fashion and sex and grief, life, right? And we've had so much feedback from you about your own messy middles that we have decided to make a season all about that, about you and the challenges that you're facing. The next season of Mid is all about dilemmas and wisdom and sharing both those things. And I am phoning in my friends to help. Hopefully, we're going to sort it out. And me and my more qualified mates, we are really going there. Mid, Conversations for Gen X Women Who Are Anything But, is back in your ears with your questions on Tuesday, July 15th.
Professor Rodney Baber is a clinical professor of obstetrics and gynecology at the University of Sydney. And today, he is going to answer some of the questions all us hot, ragey, itchy, forgetful bitches are asking about HRT or MHT. And I say the word bitch from the most loving place in my heart.
Well, I guess the first place we have to start with this conversation is with that 2002 Women's Health Initiative study. The result of it was widely publicised. It led an entire generation of not just women but doctors to believe that it caused breast cancer amongst other health issues. Can you tell us a little bit more about that study and what we have since discovered about those findings and how it's changed how we think now?
Sure. Well, the study was called the Women's Health Initiative. They recruited about 27,000 American women from various sites all across the country. It's what's called a randomized trial. So the women were randomized to receive placebos or active hormone therapy, and they were followed for between 5 and about 7.5 years, depending on the type of hormone therapy. And the drama was that when it was released, the authors said that it caused a 24% increase in the risk of breast cancer. So you can imagine what an effect that had. When that trial was conceived back in the 1990s, the commonly used hormones for postmenopausal women were the two that we used in this trial, a product which at the time was extracted from the urine of pregnant horses. So it was a mixture of a whole lot of different estrogens and a synthetic progestogen. So the first thing we've learned is that you're better off using body-identical hormones. The other things we learned was that the average age of the women in this trial was 63. So the question wasn't, does hormone therapy work? The question was, will hormone therapy reduce the risk of heart disease? And if you started at the age of 63, it certainly doesn't. But when we looked at the absolute risk of breast cancer in this trial for women right through the trial, average age 63, the absolute risk was 8 extra cases per 10,000 women per year after 5 years of taking hormones. If women took estrogen alone, Claire, their risk of breast cancer was not increased. Those women have now been followed for 20 years. And we also know that for women taking estrogen and progestogen, the risk of death from breast cancer was not increased after 20 years of follow-up. And for the women who took estrogen alone, the risk of breast cancer was reduced.
So when you say body-identical hormones different from the ones that were used in that study, what do we know about that and the links, or if there are any, to breast cancer risk?
As far as we can tell, the effect of the conjugated estrogens, which is the estrogen women's ovaries produce, is the same. But we do know the link between progesterone, which is what women's ovaries produce, and synthetic progestogens is very different. The synthetics increase the risk of breast cancer, but they also increase some cardiovascular risks as well. So we don't get estrogen and progesterone from women's ovaries, of course. So they're not from the body, but they're identical to what the body produces.
I guess the overarching question is MHT safe?
What we need to think about in terms of this is any risk associated with the use of hormone therapy is very low. And that risk has to be weighed up against the benefits which each individual woman is going to gain from using the hormone therapy. The principal indication, of course, is to alleviate symptoms, hot flushes, night sweats, muscle and joint aches and pains, and to some extent, poor sleep. And we certainly think for estrogen alone, particularly if it's used around the time of the menopause, there are some cardiovascular benefits as well.
I have been seeing a lot of people online saying, as you mentioned, that estrogen alone actually reduces breast cancer risk, but progesterone, if you still have your uterus, could lead to an increased risk of uterine cancer. What's the reality of that claim?
That's a very good question, and it illustrates a bit of confusion with the people. In fact, if you still have a uterus, progesterone is very important. So if you use estrogen alone, that will stimulate the lining of the uterus, which is called the endometrium. And if that's stimulated long enough and hard enough, it'll become unusual, atypical, and then a cancer. But if you add progesterone to it, that stops the cancer from ever getting started.
What's the difference between an estrogen patch versus estrogen gel? Because the patches have been in short supply, so a lot of women have had to shift to gel in recent years. I read that the patches are more efficient, and then some people say the gel is more effective. Like, what's the difference between the two?
Nothing. I mean, really, it's an individual thing. So if you and I lived in North Queensland, we'd probably be way better off to use a gel because the patches don't stick so well in hot climates. But in average circumstances, it's a personal preference. In Australia, we had patches before we had gels. In Europe, they had gels before they had patches, but it's a personal choice. If you use X pumps of gel or whatever, then it is exactly the same as the similar dose of patch.
Does the hormone in the progesterone IUD work the same as the MHT oral progesterone?
It does, but it's a synthetic progestogen in a very tiny dose. A small amount is absorbed into your body, about the same amount as you would see if you were taking a mini birth control pill, but it mostly acts directly on the endometrium because that's where it's sitting in the middle of the uterus. It's, of course, contraceptive, and it's also effective to control heavy menstrual bleeding.
How early can you start using MHT or HRT, and how long can you keep using it? It does seem like there is some confusion with women trying to get it prescribed by their GPs about whether they can continue taking it for 20 years, for example, as they transition from perimenopause into menopause and beyond, or whether it's a short-term solution to handle the symptoms when they're at their worst.
So answer the first question is you can start as soon as you need to. As soon as you have vasomotor symptoms, which are demonstrably due to the menopause, and that's important. So some people get hot flushes because they're anxious or nervous or stressed, or they can get it from a reaction to a food, or even alcohol can give you flushes. So it's important that you understand that the flushes are due to the menopause or the perimenopause, which is what comes first, of course. But there's no fixed date. In fact, we know that about 4% of women in Australia will go through a premature menopause before the age of 40. So if your doctor says you're too young, that's not a good enough answer. Ask your doctor to explain why you're too young. If it's obviously not due to the menopause, that's fine. Otherwise, there is no too young. There is really either no too old. We normally suggest that if you started on menopausal hormone therapy for the relief of symptoms, we usually plan to review you within 2 or 3 months. First of all, to make sure that it was working. Secondly, to make sure you were happy. And thirdly, to be honest, to make sure you were taking it. And if you were happy and were going on with it, then the recommendations these days are that it should be reviewed every year. And the decision whether to continue or not is a simple equation of what is it doing for you and what are the harms of going on. The harms of going on really are minimal, as we've just said, and probably the one thing most women would be concerned about is breast cancer. And as I said, that's 8 extra cases per 10,000 women per year, but not until after 5 years of use.
Can women who've had a hysterectomy use MHT?
They certainly can, but they don't need to use that progestogen. All they need to do is use estrogen. And of course, estrogen probably is the ideal solution. It doesn't seem to increase the risk of breast cancer at all, and it'll alleviate all the symptoms. And it's certainly the key thing in terms of cardiovascular health.
Why do some people say that they feel worse after they start MHT? I was watching a video the other day suggesting it might have something to do with a histamine response.
You certainly could. Mostly this is a dose-related effect. So we do encourage doctors to start their patients on a low dose, at the same time warning that might not get rid of the symptoms in a flash. But if you start with a higher dose, you can get bloating, you can have mood changes, you can put on weight, you can get headaches, and the chance of you having unexpected bleeding, if you do have a uterus, is increased. Some people just don't tolerate oral hormones, and to some extent that could be a histamine response related to the gut. But for those women, you can, of course, use transdermal hormones.
In what cases would MHT, HRT not be an option?
Well, first of all, unexplained bleeding, because that has to be sorted out first, menstrual bleeding or postmenopausal bleeding. But secondly, any hormone-dependent cancer. So we do not recommend the use of MHT or HRT after somebody has had a diagnosis of breast cancer, not even if they have a hormone receptor negative breast cancer, although there's some debate around that. We don't recommend it for some types of endometrial cancer, but not all. It seems to be okay for ovarian cancer. We don't recommend it if somebody has had an acute medical event, whether that was acute liver disease, acute kidney disease, or of course acute heart disease. That's not because it might cause more harm. It's because you should be sorting out those acute problems before you start adding any other medicines. And there are a few other women where you would obviously use it with some caution. People who had a history of gallbladder disease, for example, people who perhaps had an increased risk of thromboembolic disease.
If in those cases HRT, MHT is not an option, Are there alternatives for women in that situation who are suffering from symptoms of menopause?
There certainly are. And most women will have tried all the over-the-counter alternatives before they ever get to the doctor. But we do have a range of other treatments. There's cognitive behavioural therapy, which can be accessed online. There is hypnosis, again, which can be accessed online. And there are a range of prescription medications. Yeah, we have a lot of good options available for people who would prefer not to use hormones or who can't use hormones.
Just a quick reminder too, with all this information about HRT/MHT, every single person is unique. So you need to make sure you talk to your GP about your individual circumstances so that you get the right advice that's best for you.
Oh, Mariam, HRT, MHT is quite the minefield.
Mm-hmm.
What do you say to patients who either feel that they are still scared about that information that it causes breast cancer, or who are trying to get and are warned off by their healthcare professional about it because of that supposed link to breast cancer?
Yeah, we're still seeing the effects of that today.
I literally heard after that went public, people flushed it down the toilet.
Yeah. And the thing is, the study was widely misinterpreted. What we know now that is based on high quality, more recent evidence is that for healthy women under the age of 60 or within 10 years of menopause, HRT or MHT can improve those symptoms like hot flushes, mood, sleep, libido, can even protect your bones and your heart. And we now have safer forms like transdermal estrogen and micronized progesterone that carry even lower risk. So what do I say to these females? Don't rely on these old headlines. Come in, let's talk, let's look at your symptoms, your history, and what actually matters to you. MHT or HRT isn't a one-size-fits-all approach or solution for many females. We have so many things to support you through this transition period. So take those fears, take those concerns, take those questions in, and your doctor will happily answer them for you.
And as we spoke to Professor Baber about, it's not the only option.
Yeah,
we have so many options to choose from now.
Exactly. You know, if it's something that you're still worried about, despite, you know, the doctor answering all those questions for you, there are non-hormonal approaches. It's not something you need to suffer in silence with.
Absolutely. Next, it is time for a quick consult for Meg. Now, she has a not-so-nice new arrival in the back door, and she's super embarrassed about it, so we are going to try and help step her through it next.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
It is quick consult time. Mariam will welcome us into her rooms in just a second. But just in case you don't know how to get a question to Dr. Mariam, a few ways you can do it. Want to remain anonymous? Easy peasy. There is a link in our show notes to what we call the waiting room. I enjoy reading all your little messages that you pop in there. Thank you very much. You can find us on TikTok, on Instagram, so chuck us a DM. I read, personally, all of them. Thank you. It's glorious. But you can go old school too and send us an email, well@mamamia.com.au.
The doctor will see you now just through here to consult room 1.
All right, Mariam, do your thing.
Thanks for waiting. How can I help you?
So Meg has a problem. She's very worried about it. Meg is also not her real name.
Okay.
She's very embarrassed by this and felt that she did not want to use her real name. Here's what she wrote.
I've spent the last year turning my health around and recently celebrated a milestone weight loss thanks to good exercise and food choices. But with that milestone, I also got hemorrhoids. What the hell? What has caused this? Can you please explain the reasons why I would get them? I don't seem to tick any of the boxes. But I have worn my belts tight recently because my jeans have become big. Could that have caused it? And do they ever go away, or am I stuck with this nightmare forever now? Help.
Oh, babe, Meg, as someone who got pregnancy-related hemorrhoids and who had to go and have surgery, didn't realise they tie them off like they do lamb's tails, so they just drop off.
Yep.
which is weird. Miriam, what advice do you have for me?
Okay, hemorrhoids, the glamorous reward nobody asked for.
Yeah.
So what's going on? First, don't panic. So hemorrhoids, they're super common, just rarely talked about at brunch. They're basically swollen veins in the back passage. And classic triggers are constipation, pregnancy, straining, lifting heavy stuff, sitting on the toilet too long looking at your phone. Please don't do that. But you say you're not ticking the usual boxes, so let's dig deeper. First up, the tight belt around your now looser jeans. Possibly a reason. Anything that increases pressure in your abdomen, including tight waistbands, can aggravate delicate plumbing downstairs. So buy some new jeans. And here's another sneaky one, which I think might be at play here, your new healthy lifestyle. If your diet has changed and it's, for instance, lowering carbs or bulk, say you're having less bread and grains and more protein.
Is this poop related?
Yeah, your
Okay.
fiber might have taken a hit. So less fiber, firmer stools, more straining, even if you don't notice it. And some people unintentionally drink less water when they're going through that weight loss phase as well, which doesn't help the situation. Okay. So what do you do now? Good news is most hemorrhoids will settle on their own. In the meantime, up the fiber, veggies, fruits, whole grains, hydrate, avoid straining or sitting on the toilet for too long. Please put the phone down. Warm sitz baths can help. And then some over-the-counter creams can help reduce the swelling and discomfort, and go easy on the heavy lifting for a bit. Buy some new jeans and just kind of stop with those tight-fitted belts. If things aren't improving, you've got bleeding, pain, it just doesn't feel right, please see your GP. Some things can be a little bit more serious, and your doctor will exclude those sinister things. And if the hemorrhoid just keeps coming back and it is a hemorrhoid, we can refer you. So no, you're not stuck in this nightmare forever. Your body's just recalibrating. Celebrate your health gains, adjust the belt notch a little looser, and maybe add a few prunes to your grocery list.
Oh, prunes.
Yeah.
Bless them. Good advice. Well, thank you, friends, for taking the time to get to know your body a little bit better today. We're learning, like, literally right alongside you. And even, Miriam, you said this to me, like, you're a GP, but you are also learning new things too as we do this.
Right. Yeah,
so we're all
it.
educating each other, which is lovely. Heads up, you do need to take everything that you have heard here today to your own doctor, because we are giving you general advice. So if you have a sneaking suspicion that you're dealing with something similar to anything that you have heard here today, or you want to find out more about MHT, or if you do have a bleedy bottom, please go and speak to your own doctor and get that specialised treatment that is right for you. Our next episode, we're talking about the science of menopause. There's a lot happening in this space. As we mentioned, menopause is being spoken about like it's never been spoken about before. So there's things like the relationship between UTIs and the use of vaginal estrogen, whether the age you get your period impacts the age that you'll go into menopause. This time in your life can impact other things like ADHD or dyslexia or anxiety. So there's lots of science going on behind menopause. So we're going to address quite a lot of those in our next episode.
Can't wait.
Which is really exciting.
Yeah.
So we'll see you for your appointment next week.
Bye-bye.
Well is produced by me, Claire Murphy, senior producers Sasha, Tannock and Sally Best, with audio production by Scott Stronach, video production by Julian Rosario, and social production by Ellie Moore.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.